Slide 1. We are going to start this second part on peri-op nursing by looking at the surgical care improvement project and prevention of post-operative infection, including surgical site infection or SCIP measures used in the peri-op and post-operative care. Slide 2. The term peri-operative is used to describe the three phases of the surgical process. Pre-operative begins the moment the patient decides to have surgery. During this phase, physical assessment, blood work, and tests are done, medications are reviewed and held or administered, and the patient education is given. Intra-op. This is the phase where the surgery is done. Intubation, which means insertion of a tracheal tube, may be placed. After surgery and when the patient is stable, the tube is removed, which is also known as extubating, and the patient is prepared for the post-operative phase. Post-op. This is the recovery phase, and it begins when the patient leaves the operating room and ends once the patient has met all discharge criteria, oftentimes extending until the follow-up appointment. Post-op nursing care should meet the needs of the patient as an individual and is influenced by the type of procedure performed, how the patient responds to the procedure, the type of anesthesia used, patient's response to the anesthesia, the patient's medical history, and any complications that arise during the post-operative phase. Slide 3. The Joint Commission launched an initiative to promote optimal outcomes for surgical patients called the Surgical Care Improvement Project Measures, or SCIP measures. This initiative was based on interventions that have been shown in research to decrease complications for surgical patients. You do not need to memorize the SCIP numbers and interventions. You do need to understand and be able to apply these evidence-based practice interventions for your surgical patient to promote optimal patient outcomes. Slide 4. The first three SCIP measures are about prophylactic antibiotic used for surgical patients. Keep in mind that these SCIP antibiotic measures are used to reduce surgical site infections. SCIP measures 1, 2, and 3 are not addressing an existing infection. So in your pharmacology, you learned that antibiotics are used to treat active infections, and they are. Antibiotics can also be used with surgical patients to help reduce the risk of developing a surgical site infection or SSI. Slide 5. We know that for maximum effectiveness, the prophylactic antibiotic must be in circulation before the first surgical incision is made. Fibrin forms once a cut is made. That is why the antibiotic must be present prior to the surgical incision. Cephalosporins are broad spectrum drugs. They are inexpensive, easy to administer, and true allergic reactions are rare. For these reasons, cephalosporins are often chosen as a prophylactic antibiotic to help reduce the occurrence of a SSI. Timing is important for the prophylactic antibiotic to work. So, most prophylactic antibiotics are scheduled to be given 1 hour before the surgical incision is made. Levofloxacin and vancomycin should be administered 2 hours prior to the surgical incision being made. But why? Slide 6. A normal blood glucose level, or BGL, is 70 to 110. High glucose levels, whether diabetic or not, can impair the body's natural immune system, therefore increasing the risk of infection. Evidence-based practice has suggested keeping blood glucose level under 200 during the pre-op and immediate post-op phase will decrease the risk of infections in our patients. Risk of infections is significantly higher for patients undergoing cardiac surgical procedures, regardless of if they are diabetic. Various risk factors are associated with SSI in cardiac surgery, which includes age, nutritional status, tobacco use, obesity, diabetes, coexistence of infections in other sites, maybe the length of pre-op stay, skin preparation, mechanical ventilation, failure to comply with aseptic techniques, inadequate hand hygiene, maybe those distractions in the OR, number of times the doors are open, and other environment-related factors. Bundles of preventive measures applied to surgical procedures have been effective in reducing infection rates. These measures include delivering antibiotic prophylaxis within 1 hour before incision, discontinuing antibiotic use within 48 hours after cardiac surgery, performing hair removal during the immediate pre-op period, maintaining intra-op normothermia of 35.5 degrees Celsius or more, and blood glucose control during the immediate post-operative period extended to 48 hours after the procedure. Slide 7. Surgical site prep will be done the night before and morning of surgery and will include a skin prep solution to be applied that will remove microbials from the skin to reduce SSI. One common solution is chlorhexidine gluconate or CHG, and it can come in the form of a pre-moist wipe or bottled solution. SCIP measure number 6 tells us that clipping of hair around the surgical site is done in the OR or pre-op holding immediately prior to the surgery. Slide 8. To reduce the risk of infection, the indwelling urinary catheter that is placed for surgery should be removed by post-op day number 2. If the catheter is not going to be removed, the patient must meet criteria to continue with the catheter, and this reason must be documented. For example, if a patient has had a urologic operation, then the patient may meet the criteria for continuing with an indwelling urinary catheter in place. It is the nurse's responsibility to discuss criteria with the healthcare provider and document if the catheter remains past post-op day number 2. Slide 9. If a patient is prescribed a beta blocker as part of their daily home medication regimen, we want to give the patient their prescribed beta blocker on the day of surgery. If the patient has an NPO order, this is something we would clarify with the surgeon. Chances are the surgeon will want the patient to have their beta blocker unless their heart rate is 50 or less and their systolic blood pressure is 100 or less. The patient needs to have taken their beta blocker within 24 hours of the surgery start time. Slide 10. So why should we give a beta blocker before surgery? To reduce the risk of perioperative myocardial ischemia or PMI, which occurs because of a decreased oxygen supply to the cardiac muscle and is thought to be caused by the exaggerated sympathetic response that leads to a persistently elevated heart rate. This is seen in non-cardiac surgical cases. The use of a beta blocker will help reduce the risk of a PMI. Slide 11. VTE or venous thromboembolism prophylaxis may be mechanical, which is your SCDs, your TED-HOs, or pharmacological, which is your anticoagulants. This measure is in place to prevent the development of blood clots. Before surgery, they are often mechanical. After surgery, the VTE prophylaxis can be pharmacological and mechanical. It is not uncommon for post-op patients to be on subcutaneous heparin or enoxaparin along with the SCDs and PEDHOs. Timing is important. Patients should receive VTE prophylaxis interventions 24 hours before surgery and within 24 hours after the anesthesia has ended. Slide 12. The goal of maintaining normothermia of 96.8 Fahrenheit within 15 minutes of anesthesia end time is to reduce the potential for surgical site infections. How does hypothermia cause surgical site infection? So hypothermia may increase patient susceptibility to perioperative wound infections by causing vasoconstriction and impaired immunity. The presence of sufficient intraoperative hypothermia triggers thermoregulatory vasoconstriction, and postoperative vasoconstriction is universal in patients with hypothermia. Consequently, body temperature typically decreases about 4 degrees Fahrenheit in unwarmed surgical patients. This sort of moderate hypothermia can increase the risk of SSIs. Therefore, warming surgical patients to help prevent hypothermia is now the standard of care. Good temperature control will reduce surgical site infections and support good wound healing. For this reason, hospitals are now warming up their patients in the pre-op holding room. Who wants to be shivering anyway prior to surgery? They are nervous enough without being cold also. Another factor is that delay in wound closure puts the patient at a higher risk for becoming hypothermic, which means a prolonged hospitalization, and this is especially true for abdominal surgeries. An area where hypothermia is permitted is during cardiac surgery. Therapeutic hypothermia is a type of treatment. It's sometimes used for people who are unresponsive and have had a cardiac arrest. Once the heart starts beating again, healthcare providers use cooling devices to lower body temperature for a short time. It's lowered to around 89 degrees Fahrenheit to 93 degrees Fahrenheit. The treatment usually lasts about 24 hours. Unless hypothermia is intentional, we want our patients to maintain a temperature of 96.8 degrees Fahrenheit within 15 minutes of anesthesia end time. Slide 13. This is basically a review of peri-op pharmacology slides. Some medications that you need to know that can be used in the OR: opioids, antiemetics, H2 receptor antagonist or your anti-ulcer, analgesics or non-opioids, your anti-anxiety, anticholinergics, and antibiotics. Slide 14. Opiates. So basically it decreases pain of pre-op procedures. It eases induction of anesthesia. This one decreases anesthesia requirements during surgery. These medications may also be used to manage pain post-operative. Sublimize is basically the same as fentanyl. Once the patient has received opiate or anti-anxiety meds, patient is not to get up out of bed. If they must void, give them a bedpan or urinal. Risk. Slide 15. Antiemetic medications are commonly administered in the pre and post-op phase. Anesthesia affects each patient differently, but it is not uncommon for anesthesia to contribute to nausea and vomiting in the post-operative phase. When administering antiemetics, the nurse should assess intake and output, fluid and electrolytes, the effectiveness of the medication's intended use, and monitor for adverse effects such as diarrhea, tachycardia, and angina. Prototypes are ondansetron, promethazine, and metoclopramide hydrochloride. Slide 16. Why are H2 blockers given before surgery? Well, they help control nausea and vomiting as well as decreases gastric acid secretion, which may cause ulcers. They do not affect the pH of the gastric contents that may already be present in the stomach and therefore must be given some time in advance of general anesthesia in order to be fully effective. Your examples are your cimetidine and ranitidine. It can be given by orally, IM, or IV. It can also be given IV piggyback over at least 5 minutes, so usually given as an IV piggyback over 30 minutes. Rapid infusion may cause hypotension, so you need to monitor the patient's blood pressure. As a nurse, you must also monitor renal function as these drugs can be toxic. Slide 17. A common non-opioid analgesic administered in the pre- and post-operative phase is acetaminophen or Tylenol, which can be given IV or via suppository. This medication will treat mild to moderate pain. Since acetaminophen is hepatotoxic, the liver, we must assess liver function labs. We must also watch for signs and symptoms of hepatotoxicity. These symptoms include rash, stomach pain, nausea and vomiting, fatigue, dark-colored urine, light-colored bowel movements, maybe jaundice, which is your yellowing of your skin and your eyes, loss of appetite, and fever. Also remember, as a nurse, you must evaluate the effectiveness of this medication as related to pain control. The maximum dose of Tylenol in a 24-hour period is 3,000 milligrams. If the pain goal is not being met, you must contact the provider for an alternative analgesic. Slide 18. In the post-op phase, opioid analgesics are intended to treat moderate to severe acute pain from the surgical procedures. They can be given during the intraoperative phase for the patient's sedation and to reduce the anesthesia requirements during surgery. Once the patient has received an opioid analgesic or an anxiolytic medication, the patient is no longer allowed to get out of bed. If they need to void once they have been given an opioid or anxiolytic, for safety reasons, we will offer them a urinal or bedpan. The nurse must also monitor level of consciousness, respiratory status, blood pressure, and of course, pulse. Naloxone is the reversal agent or antidote for your opioid analgesics. The prototypes are morphine sulfate, sublimase, and hydromorphone. Slide 19. Anxiolytics are commonly given during the pre-op and intraoperative phase. Our prototypes are midazolam and diazepam, and they are classified as your benzodiazepines. They are used to reduce anxiety, induce sedation, and induce amnesia. Anxiolytics are not used for pain control. Anxiolytics are often as an adjunct therapy to complement anesthesia. If the patient shows signs of overdose, the antidote for sedatives is flumazenil, or it's also known as romazigon. Nurses will assess for oversedation, vital signs, and of course, monitor liver function tests. Slide 20. Anticholinergics are used to decrease oral and respiratory secretions by inhibiting the action of your acetylcholine in the smooth muscle and the central nervous system. They are used to aid in relaxation, lower oral and respiratory secretions, and can also help normalize the heart rate. Right after surgery, patients may report dry mouth. This is a result of an anticholinergic use. Anticholinergics should be used cautiously with patients who have a glaucoma as it causes pupil dilation. Also, anticholinergics should be used cautiously for patients who have a cardiac history as it can increase the heart rate. Prototypes are atropine sulfate and scopolamine. Slide 21. Antibiotics may be prescribed as a prophylactic intervention to prevent SSIs, which is your SCIP number 1, 2, 3, or they may be prescribed to treat an active infection. They may also be given during any of the perioperative phases depending on their intended purpose. You always want to assess for allergic reactions and superinfections. You need to monitor renal, hepatic labs and assess the patient for new signs of infections. Prototypes include penicillin, cephalosporins, vancomycin, and levofloxacin. Slide 22. Anticoagulants are often prescribed for patients as a VTE prophylactic measure. So that's your SCIP VTE number 2. When they are prescribed to prevent blood clots from developing, they are commonly administered via the subcutaneous route and are better absorbed in the abdomen. If a patient has an active blood clot, they will require a constant IV infusion of an anticoagulant such as heparin. Surgical patients that have an existing cardiac history may be prescribed anticoagulants orally that begin the day after surgery. To determine if the patient can safely have the anticoagulant, remember to assess for signs of bleeding and to monitor your platelets, hemoglobin, and your hematocrit. What will you look at with your nurse's eyes to determine if this anticoagulant is safe for your patient? Remember, any orifice can bleed, so assess those areas. For all anticoagulants, patient teaching is universal. What do you want them to report? Review all patient teaching for anticoagulants. So no aspirin, no NSAIDs, no smoking or alcohol. Avoid sitting for long periods of time. Do not cross your legs or your ankles. You want to use electric razor and soft toothbrush. Again, avoid high amounts of green leafy veggies, your vitamin K. You want to consult your pharmacist or your healthcare provider when you're using over-the-counter medications. Some over-the-counter medications can potentiate the effects of your anticoagulants. That's the reason for that. Slide 23. The post-operative phase begins when the patient is admitted to the post-surgical recovery area and ends when the patient has met discharge criteria. The length of the post-operative phase will be determined by the type of the procedure and the presence or absence of complications after surgery. If the patient has had general anesthesia, they will be transferred to the post-anesthesia care unit, also PACU. If the patient are critical after surgery, they will be transferred to the intensive care unit or ICU for recovery. The top priority of care during this immediate post-operative phase is airway patency while the patient is recovering from the effects of anesthesia. Nursing interventions include monitoring the ECG or telemetry. You want to assess the blood pressure, heart rate, and respiratory assessments, which includes your oxygen saturations frequently. Following the immediate post-op phase, the patient may be transferred to a med-surg floor or they could probably go home, depending on the type of surgery and the progress of the patient. Slide 24. Patients are usually kept in PACU 1 to 2 hours post-surgery and they must meet specific criteria to be discharged to a med-surg floor or phase 2 recovery, or eventually discharge home. Depending on the surgery and the patient's response, some surgical patients are discharged home after recovering in the PACU, while others may need to be transferred to a med-surg floor for further nursing care. The Alderet score describes the type of criteria each patient needs to meet prior to being released from the PACU. This is a standardized, objective scoring tool to help the nurse determine if the patient is safely able to be discharged from the PACU. The Alderet scoring system assesses patient circulation, respiration, activity, and oxygen saturation. There are 2 recovery phases that the Alderet scoring system identifies. Phase 1 is when it occurs when the anesthesia has been discontinued, and phase 2 begins when the patient's protective reflexes, such as your gag and cough reflex, and motor function return, which indicates that the patient is progressing in their recovery from anesthesia. In addition to the Alderet score, the nurse is continually assessing the patient's neurologic status, pain level, presence of nausea or vomiting, temperature, as well as assessment of the surgical site. This does not mean the nurse takes the bandage off to assess the wound. However, the nurse does look at and document on the dressing that has been placed after surgery, monitoring it for the drainage. We would want to assess if there's any visible staples, sutures, drains, tubes, or lines that the patient has from surgery. We want to check the patient's nausea and vomiting to be under control because we don't want them exerting any undue pressure on the surgical site due to vomiting, and we want to keep them comfortable as they begin the recovery process. The type of anesthesia and estimated blood loss are important to assess so that the nurse will know the expected outcomes during the immediate post-op phase. For example, if the patient had local anesthesia, the recovery would be much different than a patient who had a general anesthesia. If the EBL was 50 ml, the patient may not require a blood transfusion to maintain homeostasis. However, knowing that a patient had an EBL of 600 milliliters, the nurse knows that they need to monitor the hemoglobin hematocrit and expect an order for a blood transfusion. What significant findings would the nurse report to the surgeon or anesthesiologist? Well, if the patient is not making progress towards recovery, meaning they are exhibiting prolonged unresponsiveness, maybe a decrease in level of consciousness, 92% O2 sat or less, a respiratory rate of less than 10 per minute, maybe bradycardia, tachycardia, weak or absent pulses, decreased urine output of less than 30 ml or over an hour, or bleeding that is more than expected at the incision site. In the post-op phase, we also monitor the return of bowel movements, bowel sounds, and for an adequate urinary output. Urinary retention can be related to anesthesia. Could be also from morphine and anticholinergics. Surgical patients may not have a bowel movement until post-op day number 2, and that is expected. They have been NPO and their diet has slowly been advancing, meaning they may start with ice chips once their gag reflex returns, and then progress to a clear liquid diet, then to full liquid diet, soft diet, back to their normal diet if they are able to tolerate the progression. How would you know they are not tolerating the diet progression? Well, they may experience nausea and vomiting. Slide 28. To improve gas exchange, we will stimulate the patient to take deep breaths. We may need to do a sternal rub to arouse the patient. We could also provide ordered supplemental oxygenation. Maybe elevate the head of the bed if appropriate for the surgical procedure that was just completed, and provide pain relief if we assess the cause of impaired gas exchange may be related to uncontrolled pain. Lateral positioning maintains the airway and promotes respiratory function, prevents pulling the secretion on a sedated patient in the PACU. Slide 29. Most common cause of hypoxemia during PACU recovery is atelectasis, which is the collapsing of the alveoli. If a patient has a history of smoking, the risk for developing atelectasis is increased. Hypoventilation or mechanical ventilation, ineffective deep breathing, coughing, maybe mucus plugs, and being in a recumbent position for long periods of time can cause atelectasis to occur. Atelectasis can lead to the development of pneumonia as microorganism growth occurs in the stagnant mucus. The nurse will assess decreased breath sounds due to inadequate lung expansion, which causes mucus to block the airway. Although breath sounds may be clear, they may not be heard in all lung fields. The patient may develop a low-grade fever. Slide 30. One of the best ways to prevent atelectasis is to encourage the patient to TCDB and or use of incentive spirometer multiple times during their waking hours. I like to encourage patients to practice their deep breathing each time a commercial comes on if they're watching TV. Additional basic nursing interventions are to elevate the head of the bed at least 30 degrees, provide them supplemental O2 if ordered. You may want to teach them how to splint an abdominal incision to cough and deep breathe. You could also ensure they change positions frequently and collaborate with the patient to promote early ambulation. As a nurse, it is your job to get your patients out of bed as soon as it is safely possible to do so. The worst thing we could do for our patient post-op is allow them to stay in bed after their bed rest order has been discontinued. Early ambulation provides so many benefits for our patient. It helps with pain, it awakens the bowels, it improves mentation or mood, it promotes recovery. Providing adequate hydration will also help prevent complications that occur with dehydration and will help thin any respiratory secretions, which will allow the patient to maintain airway clearance independently. The nurse will monitor IV therapy and PO therapy to ensure there is adequate hydration while not overloading the patient's circulatory system. Intake and output should be monitored and documented for every post-op patient. This is important to provide a baseline and to help identify changes from that baseline that may indicate a fluid volume, urinary, or GI problem. Slide 31. As a nurse, you must assess for signs and symptoms of ineffective airway clearance. If you hear stridor sounds, that is an emergency and you must notify immediately. This can be because of opioid overdose. So what is the antidote? Naloxone. Or the stridor can be caused by a tongue occlusion. If the cause of impaired gas exchange is related to a tongue occlusion, we would lift the chin and thrust the patient's jaw to open the airway. Again, if there is an opioid overdose causing the tongue occlusion, Narcan may need to be administered to reverse the effects of opioids. The physician may give racemic epi nebulizer to open airway. The concentration of racemic epinephrine is typically dispensed in a 2.25 concentration. That's a 22.5 milligram per ml versus the standard epinephrine of 1 milligram per ml. Racemic epi should be diluted in, you guess, 3 ml of normal solution prior to administration via nebulizer. The doctor may also give steroids IV if needed. Slide 32. Nursing diagnosis of altered body temperature. Mild temperature is 99 to 100.4 degree Fahrenheit within the first 48 hours usually reflects surgical stress response. Often not treated with antipyretic until over 100.4. It is not uncommon for a post-op patient to have a slight elevation in the temperature during the first few days after surgery. This is in response to the inflammatory process or surgical stress response that was activated by the surgical incision or procedure. If the temperature is higher than 100.4, we will need to intervene. However, the first intervention should be to get the patient to do TCDB or IS, your incentive spirometer. Slide 33. The nurse must monitor blood pressure, heart rate, and urinary output to detect altered perfusion. You want to monitor BP and heart rate every 5 minutes times 4, then every 15 minutes times 4, then every 30 minutes while in the PACU. Also, you need to do vital signs every 15 minutes times 4, every 30 minutes times 2, then every 4 hours for at least the first 24 hours post-op. Parameters for hypertension. Remember, pre-hypertension is 120 over 139 over 80 to 89. Stage 1 is your 140. Stage 1 is 140 to 159 over 90 to 99. Stage 2 is greater than 160 over 100. Remember, there needs to be an adequate blood flow for your kidneys to be able to work properly, and unless the patient has existing renal insufficiency, they should produce at least 30 ml of urine per hour. Anything less than that, the nurse should notify the physician. Slide 34. Altered tissue perfusion can lead to clots or VTE, or also known as your DVT or PE, which can ultimately end in the death of your patient. Slide 35. This slide is showing interventions to help prevent VTE or venous thromboembolism. Slide 36. A PE results as an alteration in tissue perfusion and impaired gas exchange. Embolus, Greek for plug or stopper. Lewis reports 500,000 clients are diagnosed with PEs each year in the United States. Of these, 200,000 will die. Of these survivors, 15% will die within 3 months. DVTs kill 200,000 people each year. DVTs are the main risk factor for a PE. In late 2004, David Cunniff conducted a literature search on DVTs and PEs and found that 27,000 to 57,000 cases of clinically diagnosed PE occurred in the United States. Fatal PEs in the US ages 15 to 45 occurred 240 per year. Autopsy diagnosed terminal and non-terminal patients 100,000 to 350,000 per year. Non-terminal patients 3,500 to 17,000 per year in the United States. Normally, the body lyses any small thrombi that form within the circulatory system and maintains homeostasis by adjusting the body's clotting cascade. Now, when thrombi are not broken down or fibrinolized in the peripheral vascular system, they may break free and travel with deoxygenated blood back to the heart into the lungs, obstructing the pulmonary arteries. The mechanical obstruction instigates the release in the lungs of vasoactive mediators of inflammation such as your prostaglandin, serotonin, and histamine. The inflammation constricts your bronchi, making it difficult to breathe, which leads to hemorrhage of your bronchial capillaries, possible infarctions and or infiltrates at the site or level of the pulmonary infarct. Slide 37, just look at it. Slide 38, let's look at the population at risk. You want to look at risk factors on the previous slides, such as history of hypertension, diabetes, smoking, obesity, etc. Sub-Q heparin or low molecular weight heparin, which is LMWH, and noxaparin or fragmin. So your LMWH has a greater bioavailability, more predictable dose response, and longer half-life than your heparin. Incidences, mostly common pulmonary complications in the hospital. So teaching-wise, diet needs to be low fat, hydration is important. Exercise-wise, range of motion exercises in bed, then out of bed as soon as possible. Let's not cross our legs at ankles or knees and walk frequently on long trips. Do not massage legs, and of course we want to encourage them to stop smoking. Use of compression stockings or support stockings if up on feet a lot. You may also want to encourage weight loss. Use preventative medications such as your baby aspirin if prescribed. Again, assess your if there's any history of cough or leg pain or clots, any IVs, if they have traveled recently or prolonged seating. Slide 39. Diagnosis of PE is a process of exclusion. It mimics heart problems, okay? So the most common sign and symptom is a sudden onset of shortness of breathing or dyspnea, and an increase in your heart rate and respiratory rate. So chest pain, especially when taking in a deep breath, hemoptysis, which is coughing up blood or blood-stained mucus. You may hear crackles. You could also have some jugular vein distension. Cor pulmonale occurs in 10 to 15% of PEs. You could also have fever, accentuation of your pulmonic heart sounds, maybe sudden change in your mental status. Signs and symptoms, again, will depend on the size of the clot and number of vessels occluded. Again, small may go undetected, but if frequent, could also lead to pulmonary hypertension. Medium, if you have a medium clot, pleuritic chest pain, dyspnea, bloody sputum, pleural rub. If it's a massive clot, sudden shock may have crushing chest pain, and again, sudden cor pulmonale. Slide 40. O2 sats in 80s that doesn't respond to oxygen therapy. So ABG's decrease in oxygen can be due to hyperventilation. You need your blood coag studies, get a baseline of your PT, INR, PTT, CBC, and your platelet count. Your EKG may show right ventricular hypertrophy by having tall, peaked P waves, right bundle branch block, and tachycardia. Spiral CAT scan are being used more for diagnosis of PE because they are more accurate, but is not for those patients with COPD or those allergic to dye. Patient must have a 20 gauge IV, no PIC unless a purple power PIC. Pulmonary angiogram. Injection of dye into your vasculature to see pulmonary circulation. VQ scan is basically lung scan, VQ or VP. Ventilation is basically the movement of air in and out of the lungs. Perfusion is blood flow through the lungs. This test is done in two parts, the ventilation and perfusion. Ventilation may use a radioactive gas or aerosol. Perfusion is injection of radioactive material. Pulmonary circulation system is scanned producing a map. Slide 41. ABGs or your arterial blood gas. Describe a patient that would need to be mechanically ventilated. So an O2 sat of less than 80, respirations of more than 40, level of consciousness changes, CO2 elevated with acidosis. And what are your interventions for PE? Again, thorough assessment, stay with your patient, call the doctor, prep the patient for a diagnostic test as ordered, bed rest, provide pain relief measures. If it's mild analgesia, you could use your aspirin or codeine. If it's crushing pain, they may order morphine sulfate. You may need an anti-anxiety if patient is very fearful. Slide 42, DVT or PE treatment. The patient will begin treatment on a heparin drip. Heparin is a drug that inhibits blood clotting, so it's called anticoagulant, and is used to treat people who have developed dangerous blood clots or thrombi, or have a high risk of developing them. The dosage of heparin will be adjusted based off the testing the PTT or anti-XA levels. This test indirectly measures the amount of heparin in person's blood by one of the proteins involved in blood clot known as heparin anti-XA activity. The test is used to monitor heparin therapy to ensure that a person is receiving sufficient heparin for anticoagulation without causing excess bleeding. The dosage of the drip will be adjusted based on labs of anti-XA being drawn every 6 hours. And fractioned heparin is often used for initial treatment when excessive clotting conditions are acute. It is eventually replaced by the use of oral anticoagulations or LMWH for long-term treatment to lower the risk of blood clots. For a time, patient will have both heparin IV drip and PO warfarin prescribed until warfarin can reach therapeutic levels. This is known as the warfarin bridge. So why is the patient at risk for injury or bleeding? Well, because the coagulation cascade is being interrupted and our patients will not clot properly. So what should the patient not be using? Again, no razors when on heparin drip. Slide 43, just look at it. Slide 44, this is the heparin protocol in the Ogden work textbook. Do not memorize. You do not need to memorize. But you have to know that the goal is to have PTT between 50 and 80, which is considered your therapeutic level. You also want to note when to stop infusion. New heparin protocol from North Florida. You may want to read it if you're on that hospital. Heparin uses APTT or PTT or anti-XA factor. All are found in a time blood draw and used as a protocol to guide clinical decision making and adjustments. Now for slide 45, that's for your Coumadin or warfarin. It uses PT-INR. So the therapeutic PT is 1.5 to 2 times the control, or INR is 2 to 3. Your normal PT is between 11 to 13 seconds. So slide 46, again, just look at it. Slide 47, acetaminophen or Tylenol. Regular strength basically is their 325 milligram tablets. Weekly has been shown to potentiate the effects of Coumadin, leading to an increased risk of bleeding. So you want to teach your patient, avoid sitting for prolonged periods of time. Do not cross your legs at ankles or knees. You may want to do range of motion exercises. Again, encourage to stop smoking. Use support hose. Avoid girdles or restrictive clothing. Do not massage legs. Again, vitamin K is your antidote for your warfarin. Watch those herbal supplements. Patients should avoid garlic and ginseng because they can interact with warfarin or Coumadin. Slide 48. The goal is to manage pain to allow the patient to get moving. If you want the patient to participate in physical therapy, ambulation, range of motion exercises, getting out of bed to bedside chair, participate in TCDB or ISUs, then we need to manage pain. Or it is an unrealistic expectation that the patient will participate in the activities we know will help their recovery if their pain is not controlled. So the nurse assesses the patient's vital sign, respiratory effort, level of consciousness, and pain before medicating the patient. After medicating the patient, the nurse must evaluate the response to the pain medication and ask for orders to adjust the pain med dose or frequency if the pain med is not providing therapeutic relief to the patient. If the prescribed pain med is not allowing the patient to participate in activities that support recovery, a change in dose is required. Again, we would create an IS bar and have a conversation with the healthcare provider to make these changes. It may be that too much medication is ordered or that the dose is not strong enough. Don't forget about non-pharmacological interventions that can also provide pain relief. Touch, distraction, repositioning, promoting a calm environment are all examples of things that do not require a healthcare provider order that nurses can implement for pain control. Common pain meds that are used in the post-op phase include Sublimize, hydromorphone, and morphine. The reversal agent for opioids is naloxone or Narcan. Sublimize is used mostly in the PACU and intra-op as a supplement for general anesthesia. Keep in mind that each of these pain medications, CNS and respiratory depression can occur, and that these medications are used to control moderate to severe pain. Slide 49. To control post-op pain, the nurse must physically assess the patient and include the vital signs, respiratory assessment, and pain assessment. During the first 48 hours after surgery, the patient will likely have an IV opioid pain meds ordered. They may have an epidural or regional block in place at this time too. Some patients will return from surgery with a patient-controlled analgesic or PCA device in place as well. After post-op day 2, the goal will be to transition the patient from IV medication to oral medication. During this time, an attempt will be made to manage the patient's pain without opioids if possible. If the pain is not managed with non-opioids, patient may receive a short course of PO opioids for pain control with the goal of pain relief without opioids once healing has continued. While inpatient, the nurse will pre-medicate the patient prior to working with the therapist or other activity and prior to dressing changes if appropriate. Slide 50. It is not uncommon for patients who have undergone a surgical procedure and are under general anesthesia to experience a paralytic ileus during post-op phase. Upon assessment, the nurse would find abdominal distension, tenderness, complaints of nausea and vomiting, and decreased bowel sounds. They may also complain pain that is not relieved by narcotics. So if a patient has undergone an abdominal surgery, it is expected that they will have hypoactive bowel sounds 2 to 3 days post-bowel surgery. So what is normal bowel sounds? Well, soft gurgling sounds in each quadrant heard every 5 to 20 seconds. In ensuring that the patient has adequate hydration and electrolytes will also help improve GI circulation or motility. Again, ambulation will help in increasing peristalsis. When surgical patients go under anesthesia, everything is put to sleep, including those bowels. So patient may not produce a bowel movement in the first few days post-op due to NPO status and, of course, advancing diet slowly. Not a lot of solid food in the immediate post-op period. Slide 51. Do not manipulate NG tube if patient had esophageal or stomach surgery. Call physician if you think the NG tube is not in correct place. Slide 52. Post-operative patients may experience fluid overload or hypervolemia or a deficit, which is your hypovolemia in fluid levels in circulation. This is in part to the stress response from undergoing a surgical procedure. The electrolyte levels can contribute to the fluid retention, or if IV fluids were given rapidly, that can be the cause of fluid volume overload. Fluid retention or overload can be due to stress response, your renin-angiotensin activation, sodium in your fluid retention, again, IV fluids given rapidly. While fluid deficit can occur because of the patient being dehydrated prior to surgery, maybe the amount of intraoperative blood loss, inadequate fluid replacement, and losses such as vomiting, bleeding, wound drainage, and suctioning. Remember that blood pressure is directly related to how much fluid is circulating in the body. The more fluid, increase in blood pressure. Less fluid, decrease in blood pressure. Another indicator of fluid status is the hemoglobin and hematocrit levels that can be found in your CBC lab work. If a patient is losing blood volume, this would be reflective as a decreased hemoglobin hematocrit count. Remember to monitor I's and O's and electrolyte levels for all surgical patients. For fluid deficit, pre-op dehydration, again, intra-op blood loss could be due to inadequate fluid replacement, which I already mentioned, losses such as your bleeding, wound drainage, suctioning, nausea, vomiting. If NG tube is present, strict INO required. Ask the patient about one-to-one NGT IV fluid replacement. Monitor your INO electrolyte levels for all post-op patients. Slide 53. If urinary output is less than 30 mLs per hour, again, as a nurse, what do? Assess for bladder distension, scan the bladder, assess your vital signs, look for fluid retention or deficit, and call your doctor. Slide 54. Discharge planning. So when does it begin? Again, upon admission in the pre-op phase and continues throughout the peri-operative process. Patients should be instructed on how to take medications for pain control, to avoid alcohol while on narcotics, when to contact their healthcare provider, how to manage dressing changes and wound care, how to promote healing and prevent infection, what symptoms to report to their healthcare provider, what activity limitations and rest or nutritional needs. The surgical patient is not allowed to drive or handle heavy machinery within 24 hours of procedures that require general anesthesia. Activity restrictions will be based on the type of surgical procedure that was done. The surgeon will provide the information on when activity can resume. The surgical patient is not allowed to drive or handle heavy machinery within 24 hours of the procedure that required general anesthesia, which I said earlier. Slide 55 and the rest of the slides basically are diagnoses that focus on patient-centered care.